Hello, everybody. As Donna said, my name is Carol Eastburg, and I am the MDS and RAI and OASIS Education Coordinator for the state of Nevada. I've been asked to address this topic from the viewpoint or perspective of the state surveyors, also known as health facilities inspectors. Why address incontinence, you ask? As you can see on this slide provided by HealthInsight, incontinence has been identified as the #1 quality measure issue for all 4 states in our region. If you look at the left-hand side, the blue column, incontinence in and of itself wouldn't be such a big deal if that was all there was to it. Unfortunately, incontinence is just the beginning of many other more serious issues. And as you can see, the other 4 quality measures, antipsychotics, ADLs, pneumonia vaccinations, and pain, are elevated in Nevada as well. HealthInsight has resources on their website to assist you in tackling all measures, and they will be incorporating additional resources into future learning sessions. The objectives for this presentation are to understand the updated regulations at tag F315 and F441, identify the different causes and types of incontinence, along with factors that contribute to their development, review preventative measures and the importance of proper assessment and treatment. We will also address the newly implemented Infection Prevention and Control Program, as well as the soon-to-be-implemented Antibiotic Stewardship Program. The regulation at subsection 483.25e requires that each resident who is incontinent of urine be identified, assessed, and provided appropriate treatment and services to achieve or maintain as much normal urinary function as possible. An indwelling catheter is not used unless there is valid medical justification. An indwelling catheter for which continuing use is not medically justified is discontinued as soon as clinically warranted. Services are provided to restore or improve normal bladder function to the extent possible after the removal of the catheter, and a resident with or without a catheter receives the appropriate care and services to prevent infections to the extent possible. The intent of this requirement is to ensure that a resident will not have a catheter inserted unless determined to be medically necessary. This requires that each resident be thoroughly assessed initially and regularly thereafter for any incontinence issues, and when identified, care planning and treatment must begin immediately. All residents with or without a catheter receive the appropriate care and services to prevent infections to the extent possible. Adequate hydration, staff who use best practices regarding hand hygiene, etc. will assure this. This also includes, but is not limited to, diagnostic testing for the precipitating factors, infection, type of incontinence, increasing dementia, etc. Treatment could include behavioral modification, bladder rehab or retraining, and it should start as needed, possibly upon admission. By the way, while urinary incontinence does commonly affect elderly people, it is not a normal condition of aging and should not be considered so. Urinary incontinence, or UI, defined by the International Continence Society as the involuntary loss of urine, is often a symptom of an underlying condition. Although increasing age is a risk factor for UI, UI is not a normal part of aging. Many people are misinformed and lack correct information about UI and its treatment. Whether the resident is incontinent of urine on admission or develops it after admission, the steps of assessment, monitoring, Reviewing and revising approaches to care are essential to managing incontinence and for restoring as much normal bladder function as possible. Many people who experience UI do not seek treatment because they feel embarrassed that nothing can be done to treat it, or they truly believe it is due to their advanced age. Because UI is a symptom of a condition and may be reversible, it is important to understand the causes and address it as soon as its existence is made known. And of course, if the condition is not reversible, then treatment or management of the situation is of utmost importance. We know that if not addressed, the condition can lead to a list of more serious issues, such as changes in skin integrity, up to irritation and or breakdown, infections, falls and fractures, and sleep disturbances, along with psychosocial complications, including embarrassment, loss of dignity, social withdrawal, which interferes with participation of social activities, feelings of isolation, and depression. Make sure your facility has policies and processes in place covering who is to do what and when. Education, communication, and teamwork are key. There are several types of UI, and a resident may have a combination of types. Be sure to check the resident's history and interview either the resident and or their advocate, because the more information you have, the better equipped you will be able to be to meet the needs of that resident. This slide shows the more common types of UI. I'd like to just have a quick refresher. Functional incontinence refers to loss of urine that occurs in residents whose urinary tract function is sufficiently intact that they should be able to maintain continence, but cannot remain continent because of external factors, such as the inability to get to the toilet in time. People can experience more than one type of incontinence. This is known as mixed. Usually, it's a combination of stress and urge incontinence, experienced mostly by women, but people who have severe dementia, Parkinson's disease, neurological disorders, or have had strokes can also suffer from urge and functional incontinence. Overflow incontinence is associated with leakage of small amounts of urine when the bladder has reached its maximum capacity and has become distended. Stress incontinence is caused by a malfunction of the urethral sphincter and is characterized by small amounts of leakage due to increased intra-abdominal pressure of the bladder. This can be caused by sneezing, coughing, laughing, lifting something, standing from a sitting position, climbing stairs, and basically anything causing exertion or pressure on the abdomen. Transient incontinence refers to temporary episodes of urinary incontinence that are reversible once the cause is identified and treated, such as a urinary tract infection, for instance. Urge incontinence, also known as overactive bladder, is associated with overactivity of the detrusor muscle, causing it to expel urine before the bladder is full. Urge incontinence can be caused by strokes, dementia, Alzheimer's disease, multiple sclerosis, Parkinson's disease, or injuries. Conditions such as pelvic floor atrophy in women, prostate enlargement in men, or constipation in either sex can also lead to urge incontinence. Women who are obese are four times as likely to have stress incontinence, and smokers are at greater risk too. Recent research suggests that genetic predisposition may play a role as well. And the chance of having urinary incontinence is also higher for women who have given birth to many children, especially if they delivered vaginally. However, women who have reached menopause experience incontinence in similar numbers regardless of the number of pregnancies they had or the type of delivery. This is due to a decrease in estrogen which can cause the tissue of the urethra to become thinner and weaker. Urinary retention is the inability to empty the bladder either partially or completely. This can be caused by a blockage, such as an enlarged prostate, or a cystocele, a rectocele, constipation, bladder stones, swelling caused by infection, nerve problems, and some medications. A urinary tract infection can cause incontinence or retention of urine. Because the elderly often do not experience or report symptoms that younger people have, urinary tract infections can be easily overlooked. Confusion, feelings of general discomfort, disorientation, fatigue, weakness, behavior changes, falling, or a new episode of acute incontinence have been reported common precursors to a UTI. UTIs can cause a change in behavior in older people and people with dementia. Masquerading as confusion, agitation, or withdrawal, a UTI may be the cause of behavioral changes. The person may not be able to communicate how they feel. Therefore, it is very important to be familiar with your residents and the symptoms of UTI and to seek medical help to ensure appropriate treatment. It is also important to be aware that any infection could negatively affect the level of dementia, so any changes should be quickly followed up and treated. Urosepsis is a serious infection of the urinary tract and requires immediate diagnosis and treatment. The elderly population is more susceptible to infection due to their weakened immune systems or other conditions such as diabetes, a history of corticosteroids, organ transplant, or cancer and cancer treatment. Along with urinary retention, other risk factors which contribute to developing urosepsis include fecal incontinence, immobility, and the use of indwelling catheters. Other issues triggered by incontinence include the potential for embarrassment and loss of dignity, withdrawal from activities, and depression. I'd like to take this opportunity to remind you of the fact that each resident has the right to a dignified existence. This is found in the Long-Term Care Regulations, subsection 483.10, Resident Rights. I have to tell you, I absolutely cringe when I hear caregivers use the term diaper when referring to our long-term care residents. Please do not call incontinence products diapers. They are incontinence pads or briefs or underwear, but not diapers. All right, the first step toward assuring that a resident receives appropriate treatment and services to either maintain or restore as much bladder function as possible or to treat and manage incontinence is to identify if the resident is already experiencing some level of incontinence or is at risk of developing urinary incontinence. Excuse me. This can be accomplished by reviewing the medical history and completing a thorough assessment of all factors that contribute or may predispose the resident to having UI. An important piece of this thorough assessment would be a diary of the resident's voiding pattern over a 72-hour period. Upon determining that the resident does in fact have some level of or is at risk for developing incontinence, appropriate individualized interventions should be employed. These include identifying the resident's capabilities and underlying factors that can be removed, modified, or stabilized, and then monitoring the effectiveness of the interventions and modifying them as appropriate. This may include the practitioner at their discretion referring residents to various practitioners who specialize in diagnosing and treating conditions that affect urinary function. So, what would an inspector look for and expect to see? The resident's history and physical in the medical record, along with the details of any incontinence, whether it was present upon admission, the onset, duration, and characteristics precipitating events, associated symptoms, previous treatment and/or management, the response to the interventions, and the occurrence of persistent or recurrent, if any, UTIs. Documentation of voiding patterns, which would include frequency, volume, nighttime and daytime voiding, quality of stream, and any difficulty starting a stream, and for those already experiencing urinary incontinence, voiding patterns over at least 3 days beginning upon admission, the types and amounts of incontinence products used, and if the resident is alert and oriented, they may be able to keep their own diary, which would be very helpful for your CNAs. Documentation of patterns of fluid intake, such as amounts, the time of day, alterations and potential complications, such as the swallowing issues, and also decreased or increase in urine output. Documentation of urinary tract stimulants or irritants, such as the amount and frequency of any caffeine intake. Pelvic and rectal examination to identify physical features that may directly affect urinary incontinence, such as a prolapsed uterus or bladder, prostate enlargement, significant constipation or fecal impaction, use of a urinary catheter, atrophic vaginitis, distended bladder, or bladder spasms. Results or tests or studies indicated to identify the types of urinary incontinence, which would include post-void residuals for residents who have or are at risk for urinary retention, as well as results of any urine culture if the resident has clinically significant systemic or urinary symptoms, or evaluations assessing the resident's readiness for bladder rehab program. And last but not least, a medication review, particularly those that might affect continence, such as anticholinergics, which may cause retention and possible overflow incontinence, sedative or hypnotics, which may lead to functional incontinence, diuretics, which may cause urgency, frequency, and/or overflow incontinence, and narcotics or alpha adrenergic agonists, which may cause urinary retention in men, or antagonists, which may cause stress incontinence in women, and calcium channel blockers, which may cause urinary retention. Phew. Minimally, the facility should have documentation of functional and cognition capabilities that could enhance urinary continence and limitations, and limitations that could adversely affect incontinence. Let me start that over. Minimally, the facility should have documentation of functional and cognitive capabilities that could enhance urinary continence and limitations that could adversely affect continence, such as impaired cognitive function or dementia, impaired mobility, decreased manual dexterity, the need for task segmentation, decreased upper and lower extremity muscle strength, decreased vision, or pain with movement. The type and frequency of physical assistance necessary to assist that resident to access the toilet, commode, or urinal, and the types of prompting needed to encourage urination. Pertinent diagnoses such as congestive heart failure, stroke, diabetes mellitus, obesity, and neurological disorders such as multiple sclerosis, Parkinson's disease, or tumors that could affect the urinary tract or its function. Identification of and/or potential of developing complications such as skin irritation or breakdown, and environmental factors and assistive devices that may restrict or facilitate a resident's ability to access the toilet, such as grab bars, a raised or a lowered toilet seat, inadequate lighting, the distance to toilet or bedside commode, or availability of urinals and the use of bed rails, and a possible fear of falling. Treatment includes the use of a pessary for women and Kegel exercises for both men and women. These exercises strengthen the pelvic floor muscles and can be done anywhere at any time, no equipment necessary. Of course, the ability to follow instructions and perform the exercises would depend upon the level of cognition present. Preventative measures should begin upon admission, which means the facility must be thoroughly knowledgeable regarding the resident's urinary history, including any infections and specific treatment provided, any surgeries, the resident's voiding patterns, type of incontinence if present, any recent catheterization, and limitations such as mobility issues, arthritis, etc. A detailed dynamic care plan is essential to providing the required care, which includes timely revisions so that issues which come up can be addressed immediately. The care plan should be up to date at all times. All caregivers need to be continually observing and communicating with the rest of the team to provide seamless, individualized care for each resident. And as always, communication plays a very important role in providing appropriate care for each resident wherever they may be on the care continuum. Does your facility have a process in place to ensure proper ongoing assessment and care for the resident who is either incontinent or becomes incontinent? The sooner it is recognized, the sooner it can be addressed. And if it is possible to be reversed, it is imperative to address it immediately. Your facility needs to have a process in place that all staff are familiar with and then follow it. And health facility inspectors or surveyors will be looking for evidence of this as well.